Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. Here at Doc Buddy, of course, we deliver healthcare solutions that take the pain and cost out of broken workflows. And today we're joined by Dr. David Norris. Dr. Norris is a practicing anesthesiologist who works to improve the business intelligence of all healthcare providers. When he's non-clinical, he serves as a consultant and educator, helping physicians and practices survive and thrive by teaching the business knowledge they need to create their desired practice. Dr. Norris, thanks for joining us.
Yeah, great. It's a pleasure to be here. Thanks for having me.
The pleasure's all ours. Thanks for carving out a little bit of your calendar to spend with the Doc Buddy Journal. That's a pretty succinct intro on my part. What else should our listeners know about you?
Well, I started that journey, well over 14 years ago. Actually, longer than that. It was when I got out of residency and fellowship and got elected positions of leadership. I realized I was ill prepared to run a private practice, right? And I didn't know. I was handed income statements and other financial reports and didn't really fully understand what I was looking at. But yet I was expected to make business decisions. So in order to do my best by not only the partners and other physicians, but all the other employees that we have in the practice, I decided I'd go back and get an MBA. And as a result of that, I realized I wasn't the only physician in this situation. I just happened to be one of the few who decided to go off and get a formal degree. I don't necessarily believe you need a formal degree to get the information and the knowledge, but for me, it was the fastest way and the most concise way to get that information. And then after that, I started writing and speaking and teaching about business to residents and other physicians and other medical societies. And then wrote 2 books. The first one was Financially Intelligent Physician. That way, I walk you through financial decision making. How do you read income statements? How do you determine the financial health of a practice or business? The next one was about process improvement and really geared at patient satisfaction and trying to get the physician or the provider to think patient satisfaction goes far beyond what we do for them. It goes far beyond the right diagnosis and the right treatment. It's actually the entire encounter and how the patient feels at the end of that encounter, because patient satisfaction is really more about what they perceive our patient care to be, not really what we perceive our patient care to be. And that really began to resonate with me as my parents became older and began to consume healthcare. I really began to realize that, yes, you have great doctors, but you have bad processes that necessarily they impact the patient's perception of your care. For example, billing or revenue cycle management, not getting that EOB or not getting that bill submitted right. And then, my dad would get the bill from the oncologist and it was always wrong. And he's like, how can I trust him to be a good doctor if his office can't get that right? And I was trying to say, Dad, those are really 2 separate things. As a physician or provider, we think of those 2 separate things. But really, as a patient, that's one continuum or one continuous experience of our practice. And that's really what that book's about, is trying to get you to think about that differently. And how do you identify those bottlenecks? How do you identify those touch points and reinforce for the patient the emotions that you want that patient to feel as they go through your practice? And I think some things, sometimes the tech helps and sometimes the tech hurts. It just depends on how well you have that set up. And one thing I think is if you buy tech or you get something like that and you put it on automatic, it's not always automated. And I think that some people turn a switch and they forget to go back and check, is it working the way we want? How often do we need to audit and make certain that we're getting the results that we want out of it? And I think some people forget to do that, or it never occurs to them. They just flip a switch and, okay, it's on, great. So, and then I have another series of 4 little books coming out here in a month or 2. And they're called My Grand Rounds for Your Practice. And they're chopped up into topics. They're quick little things you can read in a day with some things that help you think or apply what we talked about in that lesson. And it's lessons on leadership, negotiations, patient satisfaction, and finance. So that's what I've been doing. I've been trying to help physicians stay private or independent if they want, or any provider really for that matter, stay independent and own their own business and operate that in the best way that they can. But I think a lot are afraid because they don't have the knowledge. And so I'm trying to help them fill that gap.
You're so right. You're obviously an expert in the space that you look at all of these factors that touch on clinical outcomes, on a practice or a physician's revenue cycle and their earnings, and then even going as deep into patient experience, patient accessibility. Over the last 15 or so years, you've seen technology really get its tentacles into all areas of a practice. There's good technology out there. There's some not so great technology out there. And when you look at some of the surveys from the reputable sources talking about what's driving physicians to retire early, what's the source of their frustration, what's the source of their burnout, it really comes down to technology, number one. And then you mentioned independent practice versus being employed by a health system or a group. That lack of autonomy comes in as a number two factor for dissatisfaction with career. And it just doesn't seem to have to be that way. So when you look at the role of technology in physician workflows spanning that continuum, as you said, what are some words to the wise? What would you recommend?
Keep it as simple as possible, particularly for the individual as they're using the technology with the patient. I think for patients, they don't really realize that, the technology is necessarily helping the physician or the provider with the care. However, depending on how it's used in the exam room, it may appear that they're being distracted by it and not really focusing on the patient. I've been to physicians' offices where, they're typing on the computer or a laptop, or maybe it's a boom connected to a wall, right? And they're not really looking at me as they're doing the interview. I think it needs to be simpler with less clicks and something that's probably a little more mobile. Hospitals, they have a lot of capital, so they don't want things walking off, so they stick things to things that are immobile, but that also impedes, I think, more of a natural workflow. So for me, what I do is I use an iPad and we use Cerner, so I just run a Citrix emulator on my iPad, but that allows me to go right next to the patient at bedside, and I can pull up all their information, which is very handy and very, very necessary. If we can discuss their echo findings or their lab results, I can do that at bedside, but I can be facing the patient, and it's no different than holding the patient's paper chart like I used to, right, and flipping through it. It's no different. But if I have to step 3 feet away and use the thing that's attached to the wall, I think some of that interpersonal dialogue or interaction gets harmed because of that. So I think you really need to think about, when you're looking at technology, how am I going to use this in the patient's environment? How am I going to use this as I'm actually treating the patient? Some people, I think, depends on the workflow. If you don't have something, if you want to keep that patient interaction personal and you use pen and paper and then you go back to the computer, you've duplicated your work. And I think some physicians do that. They want to keep that more of a personal interaction, and they don't want to appear like I'm distracted typing on a keyboard while we're in your encounter. But at the same time, then they do duplicate the work, and I think that's where the technology gets a bad rap. It's so painful. I add hours to my day, and I think that's just because the technology or whatever vendor they're using hasn't really considered or tried to develop something to streamline that workflow for the patient or for the physician or the provider at bedside. When we went out, we actually, back years ago when we actually got money for implementing an EMR, we put in our own AIMS, our own anesthesia informatics system, went out and sourced a bunch, and the one that everybody wanted was the one that was on an iPad that you could carry on a mini or a regular iPad at bedside, and it was, use the stylus or your finger, and it was more of a tap click sort of thing with occasional text. And they all like that because it didn't really slow down the workflow when we changed from paper to that. And then it was readily accessible. So, I mean, people liked it, and it was actually pretty easy to implement. But I guarantee if we had moved it to where you had to go back to a terminal somewhere, they would have been complaining about it. So that was one thing I really considered when I went out and sourced, is how little can I disrupt the current flow of that patient encounter, yet still get the informatics that we need out of it. So
To me, that's an area where the industry at large, and certainly won't name and shame any vendors, but the lack of mobility, and then not interoperability in the data sharing sense across general populations, so to be able to take your documentation and workflow tools with you, and then have that data get back where it needs to go, if it has to go anywhere, whether it's your core EHR, or to get it back to your practice when you're rounding at the hospital. That is a head scratcher to me. And listeners of the show will know I have a long EHR background, and you're just not giving providers what they really want without
yeah,
mobility.
yeah, yeah, you're right. And and anytime you switch a vendor or you change something, there's always hiccups, and that usually creates more problems than it solves, I think. So, for example, right now, I won't name a facility, but they switched where the fax server used to automatically scan and put the documents into the EMR. It'd be come in from outside. So if, say, a physician wanted to fax over their H&P from their office because they don't have the interoperability for whatever reason, it used to get automatically put into the patient's chart. Now it goes to a fax server, then someone has to print it out and scan it back in. and it's like, wait, we're going backwards in time. Why is this?
Electronic to paper and then back electronic.
Yeah, so things like that, I think, are part of the reason for burnout or frustration on providers' parts. They're like, listen, we know what's supposed to be happening. We know where you want to go, but when you make a decision and we're not going in that direction, we begin to wonder if you know what you're doing. I mean, it's no different than like with the patient experience, right? My dad saying, is my oncologist any good because he can't get the bill right? Are our leaders any good if they don't own up to the decisions they make in terms of tech and how it impacts us taking care of patients? So I think that also causes employee satisfaction issues, if you will. So,
well, obviously we're talking about workflows here and how some of them are markedly better than others. I'd love to get your perspective and your insight that, as you're set up a hypothetical, your practice, you're shopping for a new EHR, a new software. Obviously, workflow from physician down to staff down to billing, how it's actually going to work is a really important factor and a big piece of the ROI. When you look at it big picture, are you separating out workflow from the overall ROI of an investment? We're talking about businesses here. They're businesses that help people and treat patients, but a business nonetheless. So when you have people ask, hey, I'm shopping, this one costs X, this one costs Y, and this one costs Z. How do you walk folks through that process and sort of triage what makes the most sense?
yeah, I think honestly, if you're going to seriously go look at an EHR or any sort of tech, you need to go beyond what a salesman tells you. You need to go physically look at that piece of technology in live, wild function, right, if you will. I usually don't buy cars sight unseen. I want to touch them. I want to see them. I want to drive them. I think the same thing, you need to do with an EHR. And, if you're not the first client, then they have other clients. And then take the time and go look at that technology in place, working and functioning at another facility. Interview the people, ask the people as you are walking through it, how's this tech working for you? Is it delivering everything they promised? What sort of hiccups are you having? And are those reasonable hiccups? Nothing's perfect, 100% implementation. I get that. But on the whole, did it make it easier for you? And I think you need to go look at those and evaluate those and lay eyes on those. And if not you, someone who actually is going to be using the technology. If your business manager doesn't use the technology in the patient room, I'm not certain they're the best ones to go look at it. I really do think that it takes a clinical provider who's going to be using that tech to actually go physically look at it. And in terms of ROI, I've always had a hard time putting a number on tech because I see it as an expense, not necessarily as an asset that I'm investing in. Okay. I know that's how you want to sell it, but I don't own it. It's really no different than having a subscription to Microsoft Word. You know, I don't see how I can get a return on the investment because it's not an investment. I don't own it. It's not an asset. It doesn't sit on my balance sheet. It sits on my expense or my P&L. And so all I care about is how much value am I getting for that expense? How much headache is it solving for not only my providers and the people in my office, but more importantly, my patients, and how does it impact my patients? And, some patients, they don't like change. Some patients do. I'll give you, as a personal consumer of it, one of my physician's offices about a year and a half ago, they switched providers in EMR and everything's online. I don't have a problem with that. But, they want to text you this number on your phone and then they want you to sign these PDFs. But on a little phone, on an 8.5 by 11 PDF, that can be kind of a pain in the butt to read through as you're trying to figure out what am I signing. So some of those things, I understand why they did it, but at the same time, somebody didn't really play the patient role and try and experience that. So I think as you try and figure out and source which is better, X, Y, or Z, I think you got to look at all of those and variables and say, how is it for the patient experience? Does it make it easier for them? Can anybody do it? Does everybody have to have technology in order to use it? I know everybody probably has phones these days, but not everybody. And then what's that impact on my staff? And then at the end of the day, how much headache do we really have? What were the reviews when I talked to the other clients of those companies? And then pick the one that has the most features at the best value for you and go from there. I think the other thing is some people, they get afraid of switching costs, right?
Rightfully so.
And that is a thing, but sometimes you just have to rip the Band-Aid off and move on. So it's just that's how I counsel guys is you just go look at it, get your hands on it, look at it. Which one do you like the best? Call support, see what the support team's like of that EMR. Can you get through? How quickly did they respond to you when you had an issue or someone else had an issue? Those are all the variables I think you need to look at. And like I said, I don't buy the ROI. It's an expense. What's the real value I'm buying?
That's the first time I've heard that expressed from the physician side, Dr. Norris. And you're right. I mean, how much of investment is it really if Medicare will reimburse you less if you don't buy it? Sort of a compelled expenditure in some ways.
Mm-hmm.
So going a step beyond the selection process, and again, I want to be totally clear. I am no longer in the EHR world, but spent a
Mm-hmm.
fair amount of my time in it. When you talk about implementation, it takes time to learn something new. Granted, some of the funnier anecdotes, and maybe only funny to those on the EHR side of the world, is you earn a new client, win their business. Physicians don't want to learn it. Physicians don't train on it, and they get frustrated, and they jam up your support, and they say, "Hey, this thing doesn't work like my last one did." Yeah, you got something new now. So, what are your words to the wise when you do switch technologies, whether it's an EHR or if you're adding a new technology? How important is the physician role during implementation?
Well, I mean, if you're going to spend that kind of money, you definitely want all of your providers, all your physicians engaged and able to use the technology. I think some people, they'll use that as an excuse not to do something new, right? And, a lot of us don't like being told what to do. And I think particularly physicians are like, I don't want to be told what to do, so I'm just not going to really try real hard at this. So depending on your situation, you might try and include some of those physicians, some leaders within the groups to participate and be involved in that decision-making process in the selection, and then help them train the other folks and teach the other folks how to use it. You know, everything is a little different. Menu items are different, and buttons you click for the information are different depending on the system you're in, but it's not something that's undoable. You know, I think it's just a matter of some people just digging their feet in because they don't want to deal with change. So, you know, when we implemented it, I try to involve and show as many physicians the different options in our practice. I try to get everybody involved, you know, say, hey, which ones you guys like? This is the one we're leaning towards, and this is why. Here are some benefits of the other ones. And then when we implemented it, you know, we did it at one site, got people trained up to use it. And then when we went to the other sites, it was a lot easier. We started small with that change and moved on. So, you know, ours when we implemented it was relatively easy. And I think primarily because it was good tech that it was designed with the end user, the physician or the provider in mind. It wasn't a big warehouse database, or it wasn't our revenue cycle management system that morphed into that tech, an EMR. It was really designed to be something specific for the anesthesiologist. It wasn't an afterthought. So I think part of that might have been just we selected the right piece of tech.
It makes a big difference.
It does. So
with EHRs, the battle lines have kind of been drawn. You're probably not buying your first one anymore. You might be buying your third or fourth, and you kind of know what you need it for, what you're getting into for the most part. Some of our more recent guests of the show, and you mentioned this actually yourself, around patient experience, patient accessibility is a part of that as well. What are the smart practices doing with an eye towards either new technology or refining what they already have to provide a better experience? And this is a little bit of conjecture, but as the younger generations start to be responsible for their own healthcare, we're looking at an instant gratification world. Amazon Prime, buy with one click. Uber, you get a ride without having to really do anything. There's a thought, and I'm kind of in the middle on this, but there's a thought that if I can't get what I want on my phone without having to call somebody, I'll just find a practice that'll give that to me. I'm not going to work hard or dial a number to get an appointment anymore.
Yes, I think that's true, but I think that's more specialty dependent, and the reason why a patient needs to see or go to the practice, right? If I'm scheduling with my daughter's dermatologist, I don't care. I can do it on the phone because every 6 months we're going to do a follow-up. I can do that on the phone, or we can, before we leave or after we leave, if we need to change it. It's something that I could do online versus making a phone call. Yes, even I would prefer that. However, if it's something that's probably a little more urgent, I have a kid who's got stuffy nose or running a fever, I want to get him in, I might want to talk to somebody first to see if I do need to bring them in, or is it something that I might be able to wait on? Do I really want to spend that money? Depending on, what my copays are, if I have a high deductible plan, I'm eating all of that until we're done. So I want to make certain that I really am going to be able to get the best value for my dollars if I do take a half a day off of work or whatever to bring my kid in, and it costs me $150. Having a triage thing like that, and somebody to talk to, I think is important. These robo chats only go so far. And I do think, you need somebody on the other end to say, yeah, I do think, yeah, bring him in, today, we'll get you in, and then, some things are, depending on the specialist, what did the pathology show? Do you have that back? You said you're going to let us know, in a week. It's been a week and I haven't heard anything. You might want to, get in touch with a person rather than being access to have somebody explain that to you rather than just read it online. Because that's what my mom would do, is she would read all of her reports through her patient portal. And then she's like, I'm like, that doesn't mean what you think it means, Mom. Did they explain it to you? She's like, no, my appointment's in 2 days, but I read it now. I'm like, okay, well, all right. You don't have anything to worry about. It's just a bunch of medical gobbledygook language. Translation, you're going to be fine. You're right. So, I mean, it cuts both ways, right? That instant gratification, instant access. So, how you find that, I think, is really dependent upon, the practice, who your patient population is, the type of patient you're typically dealing with, and the type of information you need to share with the patient and get from the patient.
Sure. I mean, that's a more reasonable response. And you got to be accessible 24/7. You mentioned something that's a little bit of a dog whistle to me, the robo chat. More and more of these are being powered by LLMs, large language models like Chat GPT. A lot of talk about AI, and in my view, so-called AI. Much of this is just machine learning and predictive analytics at this point. We can get into that differentiation if you'd like. But where do you see AI and so-called AI leading healthcare or being embraced by healthcare either this year or further down the line?
I see it as it can be a helpful tool, particularly when it comes to drug interactions. As patients begin to have more and more, start taking more and more drugs. Before I write a script and then hand it to the patient, if I have AI that can scan their lists and then say, oh, you have potential interactions with this med, or based on this laboratory value, we might want to adjust the dose so we don't hurt kidneys or whatnot. I see that as being very helpful and beneficial to the provider. In terms of actually trying to make a diagnosis, reading CTs or X-rays, I'm not entirely certain that that's going to happen anytime soon. Having AI, look at vital signs in the ICU and saying, hey, this particular parameter is changing, and when looking at the cohort of data, when we begin to see this trend, we know the endpoint's down here if we don't intervene soon, right? Catching those things sooner rather than later in terms of that analytics, I think would be very helpful and beneficial. Because if you have, a unit full of patients and you're relying on nurses who are capable, but they have 2 sick patients, some of those little trends can be overlooked or not even seen. Whereas if we can implement an AI or some sort of technology that can track and trend those and then flag an alert, by all means, I think that's what we're going to do. I don't think it's ever going to replace a physician, at least not in the immediate future.
No, I think you'd have a really hard time doing that. Just the patient acceptance of that as a reality, and we're not even talking about the lawyers and the actuaries that will really not like that.
Yeah. Don't know why I forgot about the lawyers.
Yeah, right. Everybody's favorite topic. And I think you're touching on where the reality of AI will be for healthcare. A lot of times it's solution in search for problem, but you're referencing taking large data sets with known outcomes, feeding that into a model, and then applying that to individual circumstance, like that example in ICU. I think that is a very viable use for it. But that's also kind of touching on another area that's maybe a little forward looking, which is truly personalized medicine, where you as a patient determine it's right to sequence my genes, and I will now know which therapies are going to be the most effective for me or which ones to stay away from. I certainly don't want to pretend to be a physician. I only know enough to be dangerous. Some of the feedback that I hear on that is that in 10 years, we're going to look back and say, how come not everybody was doing this? It'll be insane that not everybody's genome was sequenced so that they know what's coming down the pike or what's possible and which treatments that will be most effective in a given circumstance. Do you have any thoughts on that?
I think there's definite benefit for that. I mean, I know that as my dad was going through prostate cancer, that was definitely part of it. His therapy or an option for that, was to screen those and then determine which ones would be most effective and give him the longest life and the longest recovery. I do think that's important. I think you're going to have a lot of pushback on some of that just because there's just so many people. I mean, the privacy issues, and then, what happens, if I have bad genes, do I become uninsurable, or do my rates get so high? And I think having nationwide adoption on that would be very challenging on those regards. Although I do think it would be beneficial and helpful. No, I don't know enough about that right now to speak more than that. That's kind of outside my wheelhouse of what I do.
That's fair, and I'm probably getting close to my boundary on it as well. That the privacy aspect is a major concern. What happens once somebody knows how my life might unfold, or what the probabilities are for my life unfolding? Insurance to employment, whatever. Certainly wouldn't want one of the commercial providers for ancestry to be responsible for that. I wouldn't think.
Yeah, and I think that then goes to the root issue. Are we the philosophical, thing? Are we what our genes are, or can we be different? Right? Can we beat it? Can we fight it?
Yeah,
Do I get to determine my own health, or is it preordained? And I think a lot of people, not many people, are going to accept it's preordained. Well, right?
yeah.
So
But I think that's maybe a conversation to dive into after playing 18 in Scottsdale, maybe a couple cold ones.
yeah,
Would love to go deeper with you on that.
yeah.
We can come back to our core topic here: technology in a healthcare setting. I said this before we started to record at Doc Buddy. Our kind of analogy is that a lot of healthcare is still on paper film. So you take your roll of Kodak to the drugstore, you get it developed, and it's kind of a clunky process. You didn't know that at the time. You didn't know there was something better coming. But we're very much in an era of digital film in essentially all other areas of our life. So, in your view, if you do feel it's important, why is it important that healthcare needs to move to digital film across all
Well,
phases, really?
I, as someone who treats patients, um, what I do is I put patients to sleep, and I put all kinds of patients to sleep. Sometimes patients don't know what's wrong with them, or they don't know exactly what a particular event, when it happened, what happened at that event. They don't know, exactly what's wrong with their heart. They just know something's wrong with their heart, and they take medicine for it. And I think that if we had something that was far more transferable, like a JPEG, right? Upload it to the cloud, and then you could interface with it. That would make it a lot easier for providers like me. I can confirm what the patient says and dive deeper into that data. Right now, what I have to do is, if I have a patient that comes from 4 hours away, right, for their surgery, so it's a 4-hour drive here. They probably spent the night here, came in today for their surgery. I don't really want to cancel that patient. I want them to get their surgery because people invested a lot of time and money to get here. Yet at the same time, I want them to live. And so that winds up taking up some time and resources on the nursing staff, hunting down reports or hunting down data. And that's the old, like you said, hard copy film, Polaroid, if you will. Whereas if it were more digital and we had better interface some way, somehow, I could just automatically have that data. It would make that a lot easier, and it would be less stressful for me, So I think it needs to happen. I don't know what, with all these, health exchanges, how far they're really going. I don't feel that much progress has been made, but heck, even if patients, perhaps what needs to happen is a patient has their own EMR that they maintain, that they keep in the cloud. It's no different than having a Dropbox, but call it a health box or whatever. But they can put in all the forms, they could scan them in or email them in there, and then if the system doesn't interface with the EHR that their physicians are using, they at least could say, here it is, here's a link, click it and you can download it all and look at it. I mean, things like that would be very helpful and very beneficial, particularly as, patients travel across the country. You have snowbirds that migrate. Things like that would be helpful rather than trying to recreate the wheel every time, they go see a new physician or they have something new done wherever they're at. So
And there's our application for AI too. AI
yeah,
scan the health box for me and tell me this patient's history. What do I need to know? They're going in for this procedure. Where's the danger?
yeah, yeah. Find me the last, trend me what their creatinine is, and what their renal function is, or read for me the last EKGs, 3 EKGs. Would they show? Have there been any real changes? Right, things like that would be helpful, and I think that's where we could make good inroads into better healthcare for patients.
And better healthcare, obviously, being great outcomes. Maybe costs is driven down as well. What are you seeing on the reimbursement side? What are you seeing on the cost to patient side? What are the hot trends there?
Oh, my rates are getting cut left and right. Everybody wants to pay me less. So for us, at least in anesthesia, it's the labor's getting pretty expensive, and they're just sometimes just not the revenue by payers to support the cost of that. So you wind up working your people longer, harder, and they eventually can make a mistake. You know, tired humans make mistakes. That's just the way
Yeah.
it works. Um, so for us, the issues we're facing is really reimbursements, or everybody wants to cut us.
And it's really hurting the profession. At least the data bears that out. There are physicians retiring well ahead of schedule, whatever that is, ahead of the age at which they're expected to retire. You're not seeing the throughput through medical schools. At least this is what's being reported. I'm not feet on the ground to tell you this is absolute. But it appears that we've got an impending slow motion cataclysm for the availability of providers, be they anesthesiologist, primary care, everybody in between. What do you do to fix it? How do you solve for that issue?
Well, so I mean, it's very interesting because my daughter, who is in college, is waffling on going into medicine. She knows what she's getting into, having a father who's a physician. She knows what it's like to be on call and miss nights, holidays, weekends, events. But at the same time, she looks out there and she sees the headaches and the hassles that physicians have to put up with. She's also looking at the cost just the cost to get the degree. When I went through to today, that cost has gone up probably 450%
Wow.
in 25 years. And so when you roll out on the other side, you already have a primary mortgage in student loan debt, unless you can pay for it somehow. I think for her, she was like, I don't know if I want to be saddled with that. I don't know if I want to deal with all these headaches. So she's actually contemplating doing something else. I'm not encouraging her one way or the other. I just want her to pick something that she wants to do, that she finds enjoyable. But I think the shortage of providers is going to be a real problem. And I think what we need is consolidation, at least in the specialties. I think you need more PCPs, primary care physicians and whatnot out there. I didn't think those need to increase, but I do think we need some consolidation in some of the specialties.
Does that mean, Dr. Norris, rolling something like an endocrinologist and a nephrologist into one categorization? I'm not sure I follow you on
Oh,
consolidation.
no, I just, we don't need a gazillion, general surgeons, or we don't need a gazillion, gastroenterologists or orthopedic surgeons. I mean, perhaps we need a fewer of those, and we need more primary care, and figure out a way to encourage those students to transition from the higher paying specialists into perhaps the less stressful, not quite as high paying, but perhaps even more rewarding primary care of some form. And I think that the reason, and because physicians haven't done that, that's why we're seeing a rise of nurses, advanced practice nurses who are, fighting and winning the battle to be practice independently and without physician oversight. And because we just don't have enough of those individuals around. And that's I think the crisis in terms of manpower that we're going to see in healthcare in the next few years, 10 years, 15 years.
Yeah, I'm glad to see that they're winning those fights, and the states are. I don't want to say going along with it, but recognizing the real need that there is a significant shortage. I mean, I'm down here in Miami. Just a short personal anecdote. I waited 8 months for an annual physical.
Wow.
Don't fully understand why, but that just seems extravagant to me.
Well, providers, they're selling time, is what they're selling. Your physician's selling his time, and he only has so many hours in a day to sell. And if you don't have enough providers, I can't
Yeah,
sell more time than I have, so you're going to have to wait, unfortunately. So
that's fair. The supply and demand is pretty basic equation on that one. What else? What else is front of mind for you, Dr. Norris?
well, I think that what I've been thinking about, I serve as a treasurer for the Association for Independent Medicine, and we're really focused on trying to provide resources to physicians to stay independent. We're trying to help them build a database of good vendors, whether EMR or RCM or whatever it is, that they can then find these tools, work together as a or association, and really support each other and stay independent and work for themselves, set their own schedule, if you will, or build their own business. What I've found is I do meet physicians who feel burned out, who are in private practice, but they pale in the number of physicians that I meet who are burned out, who have been employed. As I go across the country, speaking at events and meeting physicians, it doesn't matter the specialty. Far more of the physicians that I meet who express strong burnout or those who are employed. And I think it goes to the point you mentioned earlier. They feel a lack of autonomy. They feel a lack of self-direction. And we're trained as physicians in med school. You make the decision, you make the diagnosis, you make the treatment therapy, and you implement it. You, all the way through until you become employed. Then it's, somebody else kind of looking over your shoulder. Are you doing everything the way we want you to? And I think that's where that conflict comes. I do still think that there's a place for private practice, and I think like direct primary care is really coming into its place. I think it's going to really grow over the next few years, and it should. I think it's an interesting model, and I know a lot of guys who are making it work, and they have good patient satisfaction. And I think areas like direct primary care, where you're going to see some cool innovations in technology, because you have entrepreneurs who are like, how do I make my life easier, but provide great care to my patients, and we take the headache out of everybody. I think you're going to see some pretty cool advances that come out of direct primary care and tech.
That brings to mind an at least semi-viral tweet thread, or I guess now an X thread. Are you familiar with healthcare's top deck of the Titanic moment? Does that ring a bell?
No, I haven't seen that, but it sounds good.
I'll send you a link to it when we're through recording. It's a lot of it's fairly far fetched, and some of it touches on AI and how something like Chat GPT will allow independent medical practices to scale infinitely to those who are willing to separate themselves from the insurance that either their employer is paying for or that they pay for themselves, and create this parallel world where it's all cash pay. I want to call it concierge medicine, but everything is just a straight up posted price, fee for service. This is how much this costs. This is how much that costs. And despite some of the very far fetched trains of thought this tweet thread had, like decision making being taken from humans and given to software, which I don't see happening anytime soon. I think there's a few gems in there where it's actually fairly well thought out. So I'll get you a link. We'll have to circle back and get your thoughts on it.
Yeah.
I have one more thought for you, Dr. Norris. You mentioned, and we've been talking about the pendulum swinging back and forth between independent practice and being an employed physician. And this is kind of parallel to it, right? But all of the investments by private equity, all of the money flowing into healthcare, particularly like in the ASC space, that seems to have an actual ROI, like we talked about earlier, in a fee for service world. What happens to the amount of interest and investment in healthcare if we end up in a more value based world than we currently are?
Well, so I always have a hard time with value based because I don't know where they get their numbers, right? How do you determine what the true value is? How do you determine which patients, um, why certain physicians don't do better than others, and with certain patients don't do better than others? And I think they're trying to, we're spending all this money. We expect excellent diabetes control and excellent hypertension control from you, Mr. Physician, or we expect no surgical site, infections ever. And if you do, you're a bad doctor or you're a bad hospital or ASC. And I think that that's great. And if you prevent those things, you prevent the cost of the complications. However, they leave out one important thing, and that's the patient. And I don't want to be cold, but when I don't use Boeing anymore, they're having issues. But when Ford makes a car, they get to source everything that goes in that car. They source all the electronics, they source the tires, the brakes, the steel. And when something comes off the line and it's wrong, they know why. In healthcare, no patient's the same. I don't get to source my patients. Well, at least I don't. Some certain people do. I'm only taking care of the beautiful, healthy people. But for me, I see a wide gamut of it, and it becomes very challenging to ensure that the exact same outcome is going to happen every time. Particularly with those individuals who really they don't do the best in taking care of themselves. Right? Everybody knows you shouldn't smoke, but patients every day tell me I smoke a pack a day. I'm like, okay, you obviously know that's bad, but you don't want to quit. Yet, if you have a complication, it makes me a bad doctor. And there's some things I can prevent, and then there are others where it's just probability, and you're rolling the dice. And if you have enough of those comorbidities, eventually you're going to come up snake eyes, and you're going to have a complication. And I think fee for service is great, and trying to move to this value is, I think you need to really look at the patients and see, maybe I get a modifier for a patient who's 500 pounds because that is a very complicated patient, and they just are. They're hard to monitor. They're hard to take care of. They're hard to move throughout the system. And maybe I should get a modifier, or I should get a little grace or something. But I know private equity is moving to ASCs. They're just, I think they'll be in there for a while, and then they'll realize this isn't for us, and we're going to bug out. Because I'm already beginning to see them exit from physician practices.
Mm.
I've known some practices, some friends who got gobbled up. And then like 5 years later, they're like, yeah, this we don't want to be in this business anymore. We're going to sell you, or we're going to get rid of you, or do you want to buy yourself back? So I think the pendulum's going to go the other way here.
Yeah, it's not a medicine, to my knowledge, isn't a line item management line of business. It isn't. So no. We will see.
Yeah.
Yeah. I was just gonna say, if there weren't any other thoughts to share, which if you had one more, would love to get it.
Oh, I mean, no, I think healthcare is a great profession, and we do good work. We just need tech to help us make that job better, easier, and more beneficial for the patients, because that's really why we're in it. And we adopt tech if it helps, and if it doesn't, we push back. I mean, for example, in anesthesia, end-tidal capnography, capnography, monitoring end-tidal gases, the pulse oximeter, huge step forward in safety in anesthesia. Tech readily adopted. I think more and more after COVID, I started using video laryngoscopy all the time. I have a little camera at the end when I intubate patients. I use it all the time now because I think it's safer and more definitive. It's easier. That sort of tech, I think, and if you can put that into the chart some way, somehow, or the interface with the patients, it'll be adopted all day long. You just got to figure out what that is. And that's that's the hard part. But now I don't think physicians are anti-tech. They're just don't make my life harder.
You're so right. And all of the utilization data of the softwares that I've been a part of over the years, there's an interesting split between smartphone use. It ends up being 96, 97% iPhone users for physicians, and then that 3 or 4% for Android. Virtually all of our clients have a Facebook profile. They're all virtually Amazon Prime subscribers. So there's certainly no aversion to technology. There's an aversion to bad technology, as you said.
Yep. That's exactly right. And I
well,
think
Dr.
if we
Norris,
could, I was going to say,
I keep interrupting you, please.
I think if we could encourage physicians to get more involved in that space and help design that tech, particularly the user interface, what feels good, what works well, rather than, they just push it out without any real, what feels to be no real end user input. I think you could get a lot of physicians interested in that, as well as make some nice advances in the development.
What are your thoughts on this split that the legacy software vendor in the space? So think of your big EHRs. Hey, physicians, we're doing everything that we can, but when Medicare says you have to capture all of these data points and we have to make them an inputable field in our software, we're doing the very best that we can for you. Is there a better way to capture that data, or do the requirements need to change, do you think?
I think the requirements need to change. Some of these things you wonder, why do you need to ask this question to every patient who's coming into the surgery center for, a hernia surgery? That question bears no benefit to the providers or the patient. It's just a box to be checked. And I think if you look at the data points and say what really needs to be asked in what situations, if you begin to, rather than blanket, everybody has to ask these questions or we have to check all these boxes no matter what, and you begin to really kind of say, well, it's not really relevant in this situation, we won't require it. If they would have put thought into it and have somebody there that actually knows and put some thought into it, you probably pare that down quite a bit, and then it becomes an easier thing. And then I think the big guys might be able to design or redo their software so that it's not just clicking a box to meet a metric. And that's frustrating. Everybody hates that. Nobody likes to check a box just because of a metric.
Well, and it's not just check a box, but it's check a box on this tab, move to the next tab, find your drop down, check this box, go to the next tab, and all the way down the line until you're at the end of the note. That's
and I've seen some software where they push that to the patient on the front end, right? And part of the patient intake questionnaire, and sometimes patients like, I don't even know what you're talking about, so I ignored it, right?
Yeah, right. But it happens.
Yeah, big government gets in the way a lot.
Well, because you said it, I won't be shy to say that you got to love the federal government getting so micro into a physician workflow for what benefit exactly? What tangible benefit does that bring the patient or the provider or the healthcare facility? I'm not sure.
Yeah. So,
well, on that rosy note, I would love for you to share, Dr. Norris, where can our listeners find more of you? Social media, your website, where can folks link up with you?
Oh, yeah, sure. I'm on LinkedIn, David Norris, MD, MBA, Facebook, David J. Norris, and my website is davidnorrismdmba.com. They can learn about me, the consulting and speaking, teaching that I do. They can learn about my books, and they can find my books on Amazon and Barnes & Noble if they're interested. So, and then if they want to shoot me an email, it's pretty simple. Just David at davidnorrismdmba.com.
Easy as that. We'll be sure we get all those links into the show notes for our listeners. Any final parting thoughts before I read us out here?
No, I mean, just I'm glad to be a physician. I enjoy it, and I just want to help other physicians regain the reason why they went to med school.
It's an important message, especially in 2024.
Yeah.
Well, Dr. Norris, I want to thank you for your time on behalf of the entire Doc Buddy team, and thank you to everyone out there in podcast land for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube so that you can always get the newest episodes of the Doc Buddy Journal. And until next time, I'm your host, Eric. Talk soon.